Mirtazapine is an antidepressant that has a pretty unique pharmacology. It is primarily used to treat depression, but it may also help with insomnia, anxiety, panic disorder, and other conditions. A handful of reports exist regarding its recreational potential, but it's rarely used in that way. The positive effects of mirtazapine include anxiety reduction, depression reduction, general mood improvement, and sleep improvement. Among the negative effects are drowsiness, dry mouth, minor cognitive impairment, lower motivation, and an increase in body weight and appetite. Though less common, the drug can also cause excessive sedation in the daytime, nausea, and headache. Compared with other antidepressants, it has a very similar efficacy to SSRIs and TCAs. It also has a faster onset than SSRIs, providing greater relief in the first few weeks of treatment. On the side effect side, mirtazapine is more likely to cause increased appetite, weight gain, dry mouth, and drowsiness, but it is less likely to cause nausea, vomiting, sweating, diarrhea, tremor, sleep issues, and sexual dysfunction. The drug may be particularly good for patients who have significant anxiety, those with pre-existing or SSRI-induced sexual dysfunction, those with insomnia, and people who could benefit from increased appetite, i.e. cancer patients. Mirtazapine has shown some potential for panic disorder, PTSD, social anxiety, OCD, and other psychiatric conditions, but more research is needed. Clear positive effects on sleep have been recorded, including in healthy people. It can increase slow-wave sleep, reduce the time it takes to fall asleep, and it does not suppress REM. Some reports of recreational use do exist, but there's not enough information to make definitive statements about its effects. One form of non-medical use is as a dream enhancer, since it may provide more intense and vivid dreams, though that also includes more intense nightmares. Mirtazapine has also been used to enhance the effects of cannabis, with anecdotal reports claiming it may add euphoria and some visual effects to the experience. A handful of reports claim the drug can produce psychedelic and deliriant-like effects, but it's not clear if that's a reliable or normal effect. According to those reports, it can at least create visual tracers and minor closed-eye visuals. Less common are reports stating it can cause true deliriant-like hallucinations, but without the same confusion and severe mental impairment. Orally, the drug's primary effects are noticeable for 4 to 10 hours, and it begins working in about 30 minutes. The half-life is around 20 hours, and the therapeutic effects may exist for a full day. Mirtazapine is very closely related to a tetracyclic antidepressant called mianserin and is the 6-ASA derivative of that drug. It has an R and an S isomer, both of which are active. It's in the lesser known NaSSA class of antidepressants, which function primarily on adrenergic and serotonergic systems. Norepinephrine and serotonin activity through the 5-HT1A receptor is increased by the drug. It's an antagonist at A2 adrenergic autoreceptors and heteroreceptors. This ends up raising the active concentrations of both norepinephrine and serotonin. At the same time, it's an antagonist at 5-HT2 and 5-HT3 receptors, which channels the serotonin activity through 5-HT1. Mirtazapine also functions as an antagonist at histamine H1 receptors. An active metabolite called desmethylmirtazapine does exist, and it contributes a little bit to the drug's activity. In medical settings, the optimal clinical range is 15 to 45 milligrams. Going beyond 45 milligrams doesn't generally offer any additional benefit. That dose is usually taken once per day in the evening. A normal starting dose is 15 milligrams, and it can be adjusted according to the patient's response. The full range of dosing can end up being 5 to 70 milligrams. In recreational settings, a light dose is 50 to 100 milligrams, a common dose is 100 to 200 milligrams, and a strong dose is over 200 milligrams. Light and common doses have anecdotally been connected to enhanced dreams, cannabis enhancement, and some minor visual effects. Mirtazapine was developed by Organon. It was introduced in the early 1980s as a derivative of mianserin, and it was studied for depression and other conditions. The FDA approved mirtazapine for depression in 1996. It has continued to be studied for various conditions, and some recreational reports have appeared. The drug is prescription only in the US and is often prescription only elsewhere. Mirtazapine is low risk for healthy people, even when large amounts are taken. At medical doses, the negative effects are usually mild and temporary, like drowsiness, dry mouth, and fatigue. Overdoses with hundreds of milligrams also don't result in dangerous physical responses. There may be temporary drowsiness and tachycardia, but nothing that would be particularly concerning for a healthy person. Even overdoses with over 500 milligrams and sometimes over a gram have led to quick, full recoveries. This is good for suicidal patients, and there has indeed been a number of failed suicide attempts with the substance. One case report involving 1.8 grams of mirtazapine represents a fairly typical significant overdose. The individual slept for 10 hours after using the drug, and then reported dizziness, nausea, tremor, blurred vision, and headache. He had a heart rate of 108 and was dehydrated. The most concerning effect was fast resolving rhabdomyolysis, further indicating that overdoses are almost always going to be non-lethal, at least until you reach multiple grams. Some overdose deaths have occurred, but they have generally featured polydrug use. Those deaths included drugs like hydrocodone, diphenhydramine, fentanyl, codeine, and citalopram. Without the presence of those drugs, it is not clear if mirtazapine would have been lethal. There is a risk of serotonin syndrome, but it is low without combinations. There are some reports of it occurring with fluoxetine, tramadol, sumatriptan, and fluvoxamine. Withdrawal might occur after weeks of consistent use, featuring dizziness, nausea, anxiety, insomnia, and panic attacks. Some of the risky combinations include MAOIs and other drugs that increase serotonin. If you have any questions about mirtazapine, feel free to leave them in the comment section. In order for the Drug Classroom to provide more education, support is necessary, and the best way to support is through Patreon at patreon.com/thedrugclassroom. You can also contribute through YouTube, PayPal, or Bitcoin. You can connect with me on Twitter at Seth A. Fitzgerald and via email at seth@thedrugclassroom.com. More information and links to references can be found on the TDC website using the link below.